We've heard ASCO and NCCN brought up time and time again. Are payers actually working in collaboration with these organizations, or are you just getting data, or are you just looking out there and saying they're there, but we can't get in the silo?
Well, we do. We do spend some time. We spend a lot of time with both ASCO and NCCN. I think everybody here I probably met in one of those particular forum at one time or the other. But I would just say that you know, they've been very receptive of not only giving us information, but also in receiving information. I know that there's been more than a few occasions where we brought back you know, changes to the guidelines and said, we don't really understand this, you know, add some clarity. Okay. And they have, you know, reacted to, responded to, and sometimes modified.
What about pathways being a tool to reduce treatment complications, all comers? Does that make sense?
Well, I think that when we look at complications, do we consider complications that result in dose reductions or stopping treatment? Do we look at serious adverse events? Do we look at hospitalizations for side effects? You could measure all of those things. I think what we've discovered in our Pathways program is that the oncology infusion nurse who's there to instruct the patient on the chemo they're getting and talk about side effects, they've benefited the most from these pathways, because now instead of 10 different regimens as first-line therapy for colon cancer, they're using one primarily. Do we have evidence that we can reduce ER visits? Yes, we do with pathways. Whether or not that's due to fewer complications, it's not clear. It's kind of all over the board when it comes to those visits.
You know, we haven't even mentioned employers yet. We've been talking about payers, we've been talking about physicians and providers and patients, but what about employers? Can they participate and they can make recommendations maybe to payers? Or
you know, they have. As a matter of fact, there's a whole body of work, the National Business Group on Health, that devoted itself to the employer's role in cancer. And they took everything out from stem to stern to say, what are all the levers that we can take across the cancer experience, whether it be education, screening, diagnostics. Many of the molecular issues that we're talking about today became part of that dialogue, all the way through the treatment experience, survivorship, and advanced care planning, really aligning not only what they would expect out of payers, but to bring all of the levers. And I'm talking about short-term disability, payment policies, return to work policies, setting tones and culture within their organizations. It's a very powerful dialogue.
All right, so there's one model where the employers actually talk to everybody and try to set the tone. Then in July 1st of this year, there's WellPoint, right? They introduced a quality initiative to offer enhanced reimbursement to oncologists who followed planned treatment regimens in an effort to save on costs. In your view, does this initiative make sense? Does it work?
First, a disclaimer.
Oh, please.
As a medical director for Aetna, you're asking me to comment on the program that's being implemented by one of our competitors.
Yes, so I am.
With apologies to Dr. Malin, my friend at WellPoint, who I think has worked hard on this program. Let's just talk briefly about what the program is. What the program is for patients with breast, colon, and lung cancer in a limited number of states, which is going to rapidly expand to a lot of states. They have offered access to a portal in which clinical information is entered and a small number of treatment choices are offered. Now, those treatment choices, if you choose to use those to treat your patient, will result in you being reimbursed the management fee for that patient for that month. They're also using the same tool to adjudicate prior authorization for drugs for which they have prior auth, whether it's on the pathway or not on the pathway. So they're not collecting data on all the patients, they're collecting data on the patients who are going to be treated with the, quote, preferred regimen, and they're collecting data on patients that are being prior authed, not everybody. Now, why is that important? For such a program to work, doctors have to be incentivized to make therapeutic decisions which favor the selected pathways. Now, we're going to presume that those selected pathways have met the evidentiary standard for quality, efficacy, and toxicity. We can bet that most of those involve use of generic drugs or a more focused use of targeted agents. That would be the economic model that would make it work. For them to make up the difference, because they're not doing this because they think this is a great idea, they're going to make a lot, they're going to pay doctors what they're worth. That's not what this is about. This is about trying to steer providers from expensive, perhaps not totally evidence-based options to less expensive options, and they're going to reward the physicians for doing that. They have to shift a certain percent. I think they're going to be challenged to do that. That's my opinion.
Okay.
But I think there are a lot of attempts, and we've seen a lot of attempts. So, you know, I'm going to pay attention to and try to learn from all of these models, competitors or not, because I don't think anyone's got the holy grail or the magic solution to move us to a place to get that.
I know.
I have opinions, that's for sure.
We'll make that the next question.
But I think at least fundamentally what we would like to do is get community-based oncologists out of the business of relying on margins on drugs to fund their practices.
Okay. I think, to me, what you described it all makes perfect sense. The paranoid in me says, why are they doing this? Is it just cheaper? And they're going to have to convince physicians that it's not just cost that's driving this whole paradigm. Right?
Well, I'll tell you why they're doing it. All right, so there's a prejudice. This prejudice is commonplace in Washington, D.C., and also in the hallowed halls of managed care, that oncologists make therapeutic decisions based on the margin of the agents they're going to deliver. The evidence is actually totally contrary to that. Therapeutic decisions. There's a lot of things that enter into the therapeutic decision making, but there's actually a fair amount of evidence now that, and one of the pieces of evidence actually came from the recently published United study, where the margin was fixed, but the doctor still prescribed all over the place, which tells you that they weren't making the decision because of the margin. That's the only conclusion you can draw from that.
I was going to go there because we have the United Healthcare study. It was published in the Journal of Oncology Practice, right? And it was based on a study conducted in collaboration with 5 medical oncology groups. The payment model in this study rewarded best treatment practices and health outcomes and not the number of prescribed drugs. It observed cost savings with bundled payment, right? Discuss the benefits and otherwise of this model and whether or not you think it works. Or.
Well, I think one of the observations is the observation Mike made, and I agree with Brian that we need to look at all models and learn from them. And philosophically, there are some good things about this, and yet I think totally ablating the margin may, or the decision-making nuances when it comes to picking drugs and regimens and supportive agents, that may not be the best thing to do. And as Mike pointed out, the prescribing was all over the place. I actually think that while philosophically the idea of trying to get physicians to think in episodes is a good thing because it gets them to think more about total cost of care, I'm not sure this really pulled it off. And the reason I say that is because we at Aetna, and the same disclaimer, we're talking about a competitor here, so I'm not trying to bash the study, we've done similar programs and we know what we've saved in hospitalizations that were averted. We know what's happened in several different ways of looking at pathway rollouts for drugs. And the hospitalization savings here were very dramatic, making me wonder about the control group. And I also, as I said before, wonder about the idea about taking away the ability to think about how you're working your economics with supportive agents, things on the margin, and the no incentivization to always select the highest value regimen. I think we can do better. Because the reason is I think oncologists can do better.
And I think Ira's making a good point in that, you know, there were other elements of the total cost of care that came out in that study. And to me, the value in that study was really having folks come in after the fact, not during the middle of a pre-auth process when the stakes were high, and really evaluating what variation existed. You know, if you read the article carefully, it talks about the variation that existed in some of those services that had I won't say they had little to do with chemotherapy, but they had much more to do with services that were not being billed directly by the oncologist, major contributors. So having that dialogue regimented and explaining and at least discussing the variance seemed to be the value of having the study to begin with.
All right, let's shift gears just a little bit.